Hello, everyone. Good morning, afternoon, or evening, depending on where you're joining us from. I know we have participants registered from all over the world, so that's really exciting for us, and we're so happy to have you here today. This session is an Ask Me Anything pregnancy and postpartum session. So Yoetzet Halacha Dina Block and I are here from the halachic side of things. I'm also Yoetzet Halacha. And Chani Finger is a nurse who works in pregnancy and postpartum, and she is here to answer your questions from the medical side of things. And so we are more than happy to answer any questions that you have. We thought it might be helpful if we structure the conversation beginning from early pregnancy stages and then progressing to like mid-pregnancy or and then labor and then postpartum, just to keep things a little more organized so that any concepts that we introduce will be easier to explain and to keep track of. But we are more than happy to answer anything. And feel free.
Just so you know, you can ask questions as we're going in the chat. There's a question and answer section where you can submit questions that will only be seen by us, the panelists, or there's a room chat which you can post things that can be seen publicly by all the participants.
Yeah, so you should see those chat options on the bottom right side of your screen. So you can feel free to submit questions whichever way you want, whatever is most comfortable for you, and we will take them as they come in.
Connie, thank you so much for joining us. We're so excited to have you here.
It's my pleasure. Thanks for having me.
All right, Shira, start us off.
So some of the most common questions that we get at the beginning of the pregnancy questions often come even before a woman is pregnant, or if she's doing taking a pregnancy test, trying to figure out if she is pregnant. One of the first questions that comes up is if she has to keep Vestot. So just to give some context to this conversation and the question, Vestot are when we expect a woman, based on halachic calculations, to be getting her period. And so the question is coming because if a woman is pregnant, we assume she's not going to be getting her period anymore. So are these Vestot calculations relevant for her, or do we just simply disregard them entirely? Dina, do you want to take that question?
Sure. So nowadays, I'm Connie, you can maybe speak to this more, but people, like, we have the ability to test for pregnancy very, very early. And sometimes, back in the day, in the times of the Gemara, they didn't usually know that they were pregnant before they missed a period. But now sometimes women do find out that they're pregnant before they miss even one period. So that's really when this question comes up, is if you were to find out that you were pregnant before you hit the time that you were expecting your next period and halakhically required to observe those Vestot and separate on those days, the question is, do you still have to separate on those days if you got a positive pregnancy test? And many poskim do say, yes, you should, still keep those Vestot that first round, even if you already got a positive pregnancy test. And then moving forward from there, since you won't get a period, you won't have any Vestot to calculate going forward. So you won't have any other Vestot throughout pregnancy, unless you did have some bleeding that was a flow during pregnancy that would create its own Vestot. But otherwise, you wouldn't have any more Vestot to keep throughout pregnancy. So I think that there is a range of opinions on that. So it's always good, as with everything we'll discuss here, to, when you have a specific question, to ask your own halachic guide, for guidance. But we want to give you some, basic overview and help you understand like what the conceptual underpinnings are of these questions, so you know what questions to ask and what issues to bring up and what information to share when you're asking your own questions.
Absolutely. Thank you, Dina. One of the other questions that comes up sometimes in early pregnancy is about subchorionic hematomas. So, Chani, do you want to give some background as to what those are and what that means from a medical standpoint?
Sure. So this is something that usually has a good outcome in terms of pregnancy, but it can be very alarming because it's a flow of blood while somebody is pregnant. The word hematoma means a collection of blood. And what happens is in early pregnancy, between the implantation, the area of the implantation of the placenta and the chorion, which is the lining of the uterus, there is a collection of blood as the placenta implants. And this happens in early pregnancy, and it can be detected by an ultrasound. And so sometimes you have people who are in earlier pregnancy and they get alarmed because there's a flow of blood and they think maybe they're miscarrying. But in truth, it's just how they will get an ultrasound to detect this. And in truth, it's just how the placenta is implanting into the uterus. So this is between the embryonic sac and the chorionic sac. So it's a collection of blood, and it usually resolves, and the bleeding stops. I can't speak to, it's definitely not a menstrual bleed. Okay, this is not your period. This is not the lining and the shedding of your uterus that's bleeding. Rather, it's the way the placenta is implanting into your uterus. So the hematoma is that collection of blood, and then the hemorrhage, subchorionic hemorrhage, is actually somebody that blood exiting and exiting the cervix, the uterus, and bleeding.
Thank you.
So fascinating, because kind of like identifying exactly where the sources of that bleeding has real halachic significance. But it's kind of like such a unique situation. So Shira, what do we say about this?
Yeah, so because this collection of blood is existing inside the uterus, and it's not existing because of like an injury to the uterus or a scratch, or sometimes we have those with certain medical procedures, but it's kind of a naturally occurring collection of blood within the uterus. Most poskim will say that it should be treated the same way we would other uterine bleeding. So sometimes women will report that they won't have that much bleeding from it. Sometimes if it's very, very early on in the pregnancy, then there'll be less blood. So if that's the case and it's only staining, then all of the rules of staining would apply. So for example, if it's found on something that is colored or on something that is not makabel tama, which in different countries, there are different considerations of what those things are. So in America, many poskim will say a panty liner, that it would be okay, or on toilet paper. If it is on something that is like a white cotton piece of clothing, then it could potentially be problematic. And also if it's something that's very large, that's in the category of staining. If it is a flow of blood, and very often it is actually a flow, then that would be considered needs of bleeding, according to many poskim. But it's definitely a good idea to reach out whenever these questions come up, because sometimes depending on specific information that you provide when you're asking the question, you may get a slightly different answer.
Chani, can you talk about on the topic of a subchorionic hematoma, can you talk a little bit about, in terms of medically speaking, like, is it safe? Let's say a woman did become nida from it. Is it safe for her to do badikot if she, became nida and she's going to be going to do shav nakim and go to the mikvah? And if she didn't become nida from it, is it safe for her to have sex, or is she going to be told to be on pelvic rest? In which case, maybe we would address kind of, other possible, physical intimacy things that a couple could do.
So it's usually a self-limited thing, which means that it's not something that, pelvic rest is usually made for something where there's a threatened pregnancy, preterm labor, or, we're threatening that the pregnancy is going to end early, so to speak. A subchorionic hematoma is something where we don't really have control over what ends up happening, whether it ends in a miscarriage, which it rarely does, or not. And in terms of badikot, you're entering the vaginal opening. However, you're not entering anywhere near the uterus. The cervix is closed. So if someone needed to do badikot, it shouldn't be a problem. Again, this is information. This is not advice. So you always have to confirm, as with your halachic authority, with your medical provider. But it's not something that enters the uterus. So it's not something that can threaten a miscarriage or something like that. So I wouldn't think that somebody needs to be on pelvic rest during a subchorionic hematoma. Again, I have the information, but I'm not the point of contact, right? In earlier pregnancy, I work on a labor and delivery unit, so I have the knowledge. But anyone under 18 weeks or so, which is when the subchorionic hematoma happens in the first trimester, doesn't actually come onto our unit. So I would imagine it might be provider specific. Maybe some people feel better being on pelvic rest, which means no intercourse, but I don't think that that's something that, would affect the loss of a pregnancy.
Okay, thank you.
Dina, do you want to talk about if someone would be advised to be on pelvic rest, what that would mean halachically?
Right. So halachically speaking, right, if no vaginal penetration is, if vaginal penetration is not advised or is not recommended from a medical perspective, so the question of whether there are other other sexual activities that the couple can engage in it really is a case specific question, and really in that, like, it's definitely a question that's worth asking, and that should be raised and should be asked, and it shouldn't, you shouldn't just assume like there's nothing we can do, and for however many weeks I'm going to be on pelvic rest, like there's just nothing to do about it. It's definitely a question that's worth asking, and that's worth discussing with the person that you turn to for halakhic guidance, and bring up all the factors and explain the situation, because there definitely might be room for leniency, allowing other types of sexual activity, and stimulation and ejaculation outside of the vagina, let's say. But it really is a case-specific question, and different post-game have different perspectives and take different positions on these questions. So it really is a case-specific question that we can't answer blanketly here, but we really do encourage you to ask about it and not assume that there are no options.
Can I also just bring up one other common cause of bleeding during pregnancy, other than a subchorionic hematoma later on in pregnancy, second, third trimester, is a placenta previa, which means that the placenta embeds itself completely over the cervix, either completely or partially over the cervix. And when it comes to that, that is something that pelvic rest is recommended for, because that is really a threat to the pregnancy ending preterm early. That's a threat to possible excessive bleeding, which will affect the placenta, which will thereby affect the fetus. And that is usually frank bleeding. Sometimes it just results in staining. Usually we'll know about it, during the 18-week anatomy scan, which is the most common prenatal test that people will have. We can also see where the placenta is embedding, and sometimes it'll be kind of low, so they'll monitor it, or it could be completely covering the cervix. So this is, there are other reasons why someone would be recommended to have pelvic rest, such as suspected preterm labor, which won't result in actual bleeding. So that, I would imagine, is different in terms of implications for whether someone is NIDA or not. But I just wanted to bring that up in case anyone has that question.
And the placenta previa, bleeding from placenta previa, is uterine bleeding.
Correct. It's directly from the placenta, which is how the placenta attaches.
Right. Right. So in that case, if the woman, if it put the woman into NIDA, so then the question, the questions of other types of intercourse being allowed while on pelvic rest are kind of irrelevant, because she's in NIDA anyway. But like you were saying, with the question of the other scenario, which now what was the other scenario you just mentioned? Right. If she just has like some other risk for preterm labor that they're putting her on pelvic rest, then it might be a more relevant question. So it's really important to bring that up. Okay.
I know a question came up in the chat. Do we want to take that question now, or?
So it's a question about postpartum. So I thought maybe we should kind of keep to our structure, our organized structure, so people stay with us, and I'll make sure we come back to that when we get up to postpartum.
Okay, we will answer all your questions. So keep sending them in. Okay, so sometimes in pregnancy, often in pregnancy, people will have transvaginal ultrasounds, and then those questions come to us saying, does anything from this procedure make me NIDA? What should I communicate to my doctor, if anything? So Hani, can you explain what a transvaginal ultrasound is, where it goes, and everything from the medical standpoint?
Yeah, so transvaginal ultrasound is most commonly used in the first trimester of pregnancy, and that's because it just helps with the imaging much more. It gets up close to the uterus and to the tiny little embryo and detecting things. So it's most commonly used in the first trimester. It does not enter the uterus. It does not enter the cervix. Again, the vagina is just a tunnel to the uterus, and the cervix is closed at that time. So the only thing that I can think of where it might cause someone to see some staining or bleeding is if it irritates the cervical area, the uterine area. And that's just kind of because it's so highly vascularized. There's so many blood vessels, and especially during pregnancy, now it's even increasing. So it can cause tiny little breakdowns of those tiny, tiny little capillaries, blood vessels, which will result in bleeding. However, if it results in bleeding, which it most commonly doesn't, and sometimes it'll a little bit in staining, but it's not coming from the actual uterus. It's not any uterine lining or placental bleeding.
Great.
Right. So
So,
that, yeah, go ahead.
yeah. So because uterine bleeding is what we're concerned about for the purposes of determining if a woman is NIDA or not. So presumably any bleeding that we would see would not be uterine and therefore not a concern NIDA wise. Sometimes if blood comes out on the wand for the on the probe, is that the term, not a wand? So if blood is found on that, usually postpartum will say that there is enough circumstantial evidence to say that it's not coming from the uterus. But if you have a specific question, or if there are any other considerations, for example, if a woman was staining prior to having this transvaginal ultrasound done, that would be more of a question that would be worth talking out with your halachic advisor. That is definitely a great question. Sometimes women ask about screening tests. So for example, genetic screening, early pregnancy screens, and sometimes screening throughout pregnancy. And so Dina, do you want to share with us some of your thoughts on those tests?
Chani, maybe you want to share with us first, like what are some of the common screenings that are done at different stages?
Sure. Okay, so I really have to gloss over this quickly because this is a topic in and of itself.
For sure, it could be a whole session.
Right. So we have the first trimester testings, which are, ultrasound, right? That's the first time when we see the heartbeat. There's another screening where we will see some blood work will be drawn, and then another ultrasound will be done. It's somewhere around 11 weeks is when it happens. And we look for different things. We look for the neck folds to see the thickness of the neck folds, because that can be an indicator for Down syndrome. There's also some blood drawn, and we also look for, this is a big one, we also look for spina bifida, which is basically a malformation of the way the spine forms, and the bottom of the spine, depending on their varying degrees, is not fully formed, and it's open to air instead of closed like it needs to be. And that can affect bodily functions in terms of innervation, right? It can affect walking, it can affect bowel and bladder control. It depends on how high it goes. So these are the most two common things that are looked at. Now, in addition to that, now we really have amazing technology where there's the NIPT screening. There's the screening where blood is drawn from the mother's vein, like right here, nothing invasive other than that. And it can detect a huge amount of different abnormalities, genetic abnormalities. It can also detect the sex of the baby. It used to be more reserved for higher risk or for advanced maternal age, but now it's becoming available to everyone. Now, it is not diagnostic. It is what we call screening. Okay, it doesn't diagnose, but it can it can bring up some red flags, which we would do further testing for. So it's just, again, a screening. It has a very high sensitivity rate, which means that it picks up, it's very sensitive to picking up things. So it's a very, very high likelihood. If it were to be positive for anything, what's commonly done now, and this used to be a lot more common, but now it's just it's not done as frequently because we have this NIPT screening. We do a I've lost my words. You know what I'm
An amnio or CVS?
Yeah. Amniocentesis or choriocentesis, which is a very small needle that's inserted into the uterus, and a small amount of either chorionic villi, which is just part of the contents of the uterus are drawn, and they're actually genetically tested. And so this enters the uterus with a small needle. There is a slight risk for miscarriage. So that's why it's great that we have the initial screening first, because then we don't even have to put the patient through a miscarriage risk. And it's more commonly done again for higher risk pregnancies, and for older people who may have a higher likelihood. Now, these are all tests, and they're multiple tests. So they're a lot more accurate than they used to be back in the day, 20, 30 years ago. And some of these prenatal screenings have gotten in the Jewish community a bad rep of like, oh, it's going to give me false results, or they're going to tell me all these scary things. My friend, my mother, they told her all these scary things and about me, and I was born normal. Now, again, we have to remember it's all just a collection of data, of information.
Right.
So this is, something that everyone has to, case by case basis, decide on. The best thing to do is to talk to your provider and say, what would be done? What would my options be, say, if we found something? And I've seen, unfortunately, that some providers kind of stereotype from Orthodox Jewish women and don't even offer them these screenings.
Wow, that's really terrible.
Big shame, which is why if you want to find out about these screenings, you need to come in and make sure that your provider knows that you want all of your options laid out for you. So again, this is first trimester testing. And besides, for, some people think it's just to abort the pregnancy. It's not necessarily that, but we do have a much more accurate picture when we do it in the first trimester. There's the 18-week anatomy scan that happens somewhere between 18 and 22 weeks, where we look at a thorough all of the body structures of the baby. Again, it's not 100%, okay? Ultrasound is limiting, but if we have more information from the first trimester screenings, then it can help us gain more accurate information, okay? Because it's all denominator numerator thing, okay? The likelihood will be greater versus all we're seeing on the anatomy scan is maybe a little bit of a thick neck or some heart thing, but we have no information from the first trimester screening. So that can make things a little bit more complicated, and that's when people will be afraid, and really everything is normal because it has a high false positive rate. So that's, a big thing to keep in mind. And then there's just usually the routine ultrasounds, there's genetic screenings, which there's not really much to do about during the actual pregnancy, but for future pregnancy. So a lot of times it's offered, but, we have commonly we do genetic screening, premarital genetic screening as it is. So these are the most common prenatal tests in terms of for the fetus. There's plenty of other prenatal tests for the mother that I'm not going to cover right now, but these are kind of the most invasive, so to speak.
Right. I think you really hit the nail on the head that every person has to, discuss with their spouse and whoever they turn to for guidance and mentorship, to bring the halachic perspective into the conversation, and, discuss what they would do with the results in figuring out, which screenings they want to do, and to really know that there's a lot of different things that, you could do with the results and you could do with the information. And it's not like terminate or don't terminate. And, that's the end of the discussion. And even the termination discussion is complicated. And I'll give a plug for another session here at the conference later today, where Rabbi Alman will be discussing termination and in halacha and from a Torah perspective. So thank you so much for that information. And we really encourage everyone to really, this whole conference is really just about empowering you and giving you tools and knowledge and information, and the more information that you have to bring to the conversation, to bring to the table, the more informed decisions you can make. Okay, so we're getting some questions in the chat, but let's keep on going here.
I think we can take the questions that came up.
Okay, sure.
Because one of the questions related to the end of late pregnancy.
Yeah, which is basically what we're up to now. So one of the questions that came in the chat is about there is a tradition that some people have as a skula to go to the mikvah in their 9th month of pregnancy. I think the skula piece is if you, someone who's struggling with infertility versus after the woman who's 9 months pregnant, that's a skula for that woman to get pregnant. As far as I know, there's not any basis for that in any halachic sources or any Kabbalistic sources or any Torah texts at all. And I think it could be it's something that I feel somewhat wary of, because, when we don't know how God works, and when it does work, when it works, quote unquote, obviously that's wonderful, but when it doesn't, that could be, that could create all sorts of complicated feelings and emotions also. Shira, I know you have the mental health background also, so maybe you have something you want to comment. Shira, Yoatzat Halacha Shira Donath is also a candidate for a PsyD in psychology, so maybe you want to comment on that also.
Sure. So I just want to add before I move into mental health aspect that there are some later sources that talk about a skula of a woman who is in her 9th month going to the mikveh for the purposes of having a child who is a ben or bas Torah. So there are some later sources for that, but I agree with that I haven't found anything that connects it to the fertility piece, which is often the more commonly asked about question. So just to give some broader context to that. I also agree with Dina that if we go into a certain practice with an expectation for specific outcomes, then it can lead to a lot of difficult emotions, if those outcomes happen or if they don't happen. So if somebody goes to the mikveh with the expectation or the hope that I will get pregnant because of this dunk in the mikveh, or if the woman in her 9th month is hoping to help her friend get pregnant because of that dunk, if that happens, then it could lead to a reliance on more of these segula type things and this like magical thinking that we have the ability to control certain outcomes. And if it doesn't happen as the outcome, then that could be really disappointing and really painful, and could also lead to questioning of can I really trust God? Or what's my relationship with God like? And so getting into these scenarios where we're almost like bargaining, right? Like, I'm going to do this thing and you're going to do this for me or for my friend. It can lead to a lot of complicated emotions in relating to God and to religion and to this practice of mikvah also. If we try to utilize it for something, for specific outcomes, it could complicate our relationship with mikvah more than it might already be complicated. So yeah, I agree with what Zina said, that just proceed with caution.
Right. As far the question specifically, is there halachically should we not do it because we don't do mikvah unnecessarily? So there's not really necessarily a halachic problem with it per se. I mean, you wouldn't say a bracha if you're not nidza and you're going to the mikvah for this type of purpose. But Chani, would you say, from your perspective, is there any medical indication to not, immerse on the mikvah 9 months pregnant?
Not that I know about. Obviously, if your water's broken, but you'd probably be in the hospital. Some people's water does break early on. That's for sure a no. But I wanted to just say back to like what you were talking about with segulos, just from a medical kind of comparison perspective, there are some medical procedures that we do where there's no guarantees. I mean, most of them, all of them, some have a higher guarantee than others. But sometimes when someone opts to do a medical procedure where they know this may or may not help, especially in pregnancy, there's so little we know. So, for example, there's the McKenna shot, the progesterone shot that someone takes if they have a history of preterm labor or miscarriage. And so it can work, it may not work. We don't have even great data on it. But if someone wants to approach doing a segula in that way, where, maybe this is something, an additional, layer or something that they can do out of their own spiritual desire, but never look at it as a guarantee. So if someone wants to go about approaching a segula with that perspective, then, it might be helpful for them.
Right. So if someone specifically wants to do this, there's not a halachic limitation that kind of forbids it. But I guess it's just kind of, it's good. Again, it's good to have the knowledge, like you would medically also, of like what's evidence based, what data there is on a certain thing for making a decision, to just know kind of what there's basis for in the sources and what less so. Okay. Person who asked that question, I hope he answered your question. You can definitely feel free to respond in the chat if you have anything else you want us to address. Okay, so in terms of late pregnancy, 9 months pregnant, you actually, Chani, just mentioned water breaking, so we can talk about that for a minute as far as nidza goes. So your water breaking does not make you nidza. And the mucus plug also, Chani, would you confirm that the mucus plug, like any blood that you see from the mucus plug, is not uterine?
Yeah, probably not. I would really, the mucus plug is so relevant, I have to tell you. It gets it gets people all, riled up for absolutely no reason. Your mucus plug can actually regenerate itself, by the way.
So interesting. Well, I feel like for a lot of frum women, maybe it gets them riled up because, like, anytime you see anything blood streaked coming out of you, you're like, oh my God, what does this mean for my life? Especially if you're not like going into labor right away. What?
Yeah, if you have no risk factors or other prior history of why you would bleed, I would probably, assume that comes from, again, the highly vascularized. Now it's even so much more vascularized. So there's so many little capillaries that can be very sensitive.
Right. So yeah, so blood from the mucus plug also is not a NIDA issue. Let's talk about membrane stripping, which is, I feel like, a really hot topic among.
I actually just want to grab, I have an orange right here, and I brought it because I think it will be a great, so why don't you talk
demonstration?
About
okay.
I'll do a good demonstration.
Okay, I feel like we need you to tell us the facts on the ground so we can address the halacha. Shira, do you want to talk about that?
Sure. So there are some general principles when it comes to if someone is in labor, what makes her nida. And if a doctor has to do certain procedures that will bring on labor, that will induce labor, what are those procedures and what are the halachic ramifications of it? So one of the fundamentals is that when a cervix dilates, that could potentially make a woman nida. Often, a woman does not get to a point of dilation that would make her nida from the dilation in and of itself until pretty far along in the labor process. There is variation between poskim, particularly between different communities, on what that amount is. In some communities, poskim are likely to say 3 centimeters dilated. In some communities, it's 10 centimeters dilated. So that really does vary depending on who your posek is or what community you align with. But a question becomes, if somebody is not dilated and they're doing a procedure in order to dilate you more, that would potentially make a woman nida. And so there are different measurements as to what size or what amount of dilation would make a woman nida. So the most commonly used measurement is 19 millimeters dilated, and but there is some variation if there's a procedure being done in order to dilate the woman more than she is already dilated. So there are different types of procedures, which Hani can talk about, that may or may not dilate the woman. But that would be one of the most common halacha considerations in determining if a woman's becoming nida from any of these induction procedures.
Okay, so membrane sweeping, membrane stripping, first of all, just to be clear, it is not, again, a surefire way to get you into labor. Providers will wait until after your 39 weeks because we don't want to induce labor prior to that. And if we are, then we're doing it the medical way. So this is something that what happens is here is an orange, all right? So here is the PO is the chorionic sac, and the inside is the amniotic sac. So usually when a membrane strip is done, it's done with, and again, this is for demonstration purposes. I'm making the hole bigger, okay? Usually your cervix is not that big yet.
Well, if you make the hole, that's part of the whole issue that we're discussing, right? If the doctor has to make the hole bigger with their finger in order to do it, then that probably would put you into nida. Whereas if it's dilated enough that the finger can get in easily, then it might not put you into nida.
Right, exactly. And that's a great point because most providers, I will tell you, will not do it if you're not dilated at all because they need to get inside of the, can you see this? Can you see my little orange?
This is a fantastic demonstration.
Amazing, I love it.
So they need to actually get inside and separate. It's not to break your water, but it's to separate. Okay, they go like this. And it kind of separates your, now I'm leaking. There's a small chance of breaking your water, very slight. So here we go. This one happened. But basically, they're kind of going inside and they're sweeping just to separate the two. And the point of that actually is for your own body to start labor because it releases something called prostaglandins, which are the early hormone which starts to try to get your body into labor, to soften your cervix. Most providers, and one finger in is 1 centimeter dilated, most providers will wait until you're 1 to 2 centimeters dilated before they can even do it, and somewhat effaced. So it's not done for the purposes of actually manually dilating your cervix, but rather it's done to help release those hormones from your those hormones from your cervical area. So it may open your cervix more just by virtue of this is how the procedure works. It goes like this, okay? But it may not also, open your cervix. That's not the intention as much as especially if your cervix is not soft. It's actually not recommended to try to manually dilate your cervix because it can cause all sorts of problems. Okay, so there's chemical versus manual, right? So we're looking at the chemical part of it, and that's really the purpose of it. It can give you some staining or bleeding. That's actually pretty common. You'll see usually in your mucus. A lot of times that is, again, because of the highly vascularized cervical area. So, it's extremely sensitive to any touch or anything. And that's kind of similar to like a bloody show, all right, which is an earlier or mid labor sometimes where you'll see some mucus stained blood, and usually again that's a sign that your cervix is changing. It's actually a great sign. We're happy when we see that, and so that's the purpose of the membrane strip, and it's not always effective. But it does have a higher likelihood of putting you into labor in the next 24 hours. And one thing you should know also is that it can be painful and uncomfortable. So if you're already not good with cervical exams, then you may want to hold off. And it can cause pretty painful cramping afterward with no guarantee that it's going to put you into labor. But at some point when people are 40 or 41 weeks pregnant and they're kind of out of options and they just want labor to start on their own, this is a more commonly offered procedure. So there's the internal cervix and the external part of the cervix. We call the internal os and the external os. So when we get into the internal os, we're really getting into like the uterus, the uterine area, versus the external os. So the internal os is more commonly something that's thought, again, you'll correct me, I know I'm going a little bit veering into halacha, but it is something that is more commonly thought to put a woman, making a woman nida in terms of dilating the uterus. But when you say finger, it's interesting because when we check a patient, we'll say fingertip, and that's basically 0.5 centimeter dilated. So by 1 centimeter, that's kind of like our finger is able to fit through the cervix.
So I guess the bottom line is, and someone I see someone is putting this in the room chat, like, does membrane stripping make a woman a nida? The bottom line is it's not so black and white, yes or no, which makes it a little bit difficult because a lot of times women will call us and they'll say, my doctor wants to do membrane stripping. They offered it to me to try to get things going. Like, is it going to, and like you said, there's no guarantees that it's going to put you into labor. So, if you're not going to go into labor, then you don't want to become nida, if you're still going to be pregnant for another couple of days, week. So, it's kind of important to discuss with the doctor exactly what stage of, progress in your getting toward labor you're at and what exactly they're going to do in the procedure, to know whether it's going to put you into nida or not. And then also if you do see any bleeding from it, if you see that bleeding, I guess, Chani, maybe
I will tell you, I will tell you that it's probably most definitely from the cervical, trauma, so to speak, the cervix, where we're irritating the very highly vascularized, kind of like when someone will get a nosebleed. Think of it that way. It's a very sensitive membrane.
Right. And then if you see bleeding after, it would be like staining anyway. You would, wear a liner, wear colored underwear, those kind of things that we talked about before. But it's not so black and white.
It certainly isn't. And it's probably helpful to have a conversation with your provider to ask them for the exact procedure, or have your Rav call and speak directly to the provider to ask all of those questions. And I do say, like, if someone is over 40 weeks or 41 weeks and say they want to have a low intervention birth. So that is, I think, something more of a topic worthy of discussion because they're coming up to the point where they may have a medical induction recommended. So, versus someone who's 39 weeks along, we don't know, or someone who's planning a home birth or a birth center birth. And if they went past 41 weeks, then they would, so to speak, risk out because they would need a medical induction. These are kind of factors that you might want to consider having a more in-depth conversation about whether this is something that, can help and whether you're willing to take the risk of becoming NIDA. It's just not very convenient for labor.
So just to clarify the bottom line that someone's asking for clarification for in the chat, the how dilated you are already before starting the procedure will impact whether or not the membrane stripping makes you NIDA or not. Because if the doctor doing the membrane strip doesn't dilate you any further, then it potentially would not make you NIDA. Otherwise, it might.
And in general, when a woman is in labor, how do you determine if she's in NIDA? There are other factors other than just dilation that are relevant.
Can I just say one thing really quick, just to backtrack?
No,
there's a common term that we use is stretching the cervix. Okay, sometimes a provider will check a patient and tell me after, oh, we stretched the cervix, her cervix was soft, so she went from 4 to 5. It'll more commonly be in repeat mothers, not a first-time mother. So it's a great term to actually use with your provider. Say you are considering membrane stripping and say, don't want my cervix to be stretched. Okay, I don't want to stretch, I don't want to stretch because that's kind of more of a manual dilation of the cervix.
That's great to know. Thank you for adding that in.
Good terminology.
Yeah. So when a woman is in labor, aside from the amount that she's dilated, some other things to think about and to pay attention to are if a woman is laboring, she's having contractions already, and she's also seeing bleeding, then we would assume that that's uterine bleeding, unless it's mucus plug. When it's actually bleeding, at that point, we would assume that it's uterine bleeding, and that would potentially make her NIDA. And then another factor is if her contractions are so intense that she can't walk unassisted between contractions. That would be another point at which we would consider her to be NIDA potentially.
It's just sometimes hard to actually assess when that is, especially if a woman has an epidural and isn't walking around anyway. Then we don't necessarily know exactly when that would be. So practically speaking, it might end up being based more on progress of labor. But in theory, looking back at the Gemara, that is one of the things that is discussed and mentioned.
Right. We use whatever information we have. So if a woman is not having an epidural and she is moving around by herself, then that would be potentially something that would be relevant to her. But not all of these are always relevant. But things to keep in mind for different types of labors and pregnancies. Okay. Is there anything else from the end of pregnancy that we think is important to address?
One question that I know that comes up sometimes with women that I talk to is the Foley balloon.
Do
you want to talk to us a little bit about what that is, what it does, how it works, and then we can address it from the NIDA perspective?
Yeah, sure. So what a Foley balloon is basically it's kind of like a thin straw with a little balloon around it. You can't see it, but it's inserted into the cervix, and the balloon is blown up to like a nice size, and it's on top of the cervix. It is a method that we use of what we call cervical ripening. So prior to the actual labor induction, we want the uterine oxytocin receptors. We want the receptors to be sensitive to the synthetic Pitocin that's given during an actual induction. And we can sometimes flood a patient with tons of synthetic Pitocin, but if their receptors are not sensitive to it, they're not going to do anything. They're not going to put them into labor. So the way we do it is by ripening a cervix. And there's actually something called the Bishop score, where we add up a bunch of characteristics of the cervix to say, oh, hey, the cervix is ripe. There's a good chance, labor is going to start and delivery is going to happen. So There's chemical, like I said earlier, there's chemical ways to soften the cervix. There's medication like misoprostol, and then there's manual ways, which is either a Cook catheter or a Foley catheter. A Cook catheter has two balloons, one on the inside that goes on the inside of the cervix, one on the outside, and a Foley is just one that goes on the top of the cervix that the nurse will tug on every few hours. And basically it puts pressure on the cervix, and it manually will dilate the cervix. And eventually it'll fall out on its own, or it will be removed by the team in about 12 hours or so. And that actually is manual dilation of the cervix. So if the patient has to have the cervix has to have enough room for us to actually put the Foley balloon in. So usually that's about 1 centimeter or so. And it will commonly cause cervical, what we think is usually the cervical mucosa lining. The lining is irritated, so we'll have like a bloody show along with that. And sometimes it can be used in combination also with the chemical, with the misoprostol or the oxytocin together. So someone who's having who's having a VBAC, that's more of a common way if we need to kind of get them into labor, because chemically we're kind of afraid of inducing too many contractions and hurting the area where the uterine scar is, causing damage. So I've seen that as a common way, because the misoprostol that's used otherwise is not something that we can use for someone who's trying for a VBAC. But it's a commonly used thing, and it can be very uncomfortable. It can cause quite some cramping.
So just to clarify, to insert the catheter itself with the balloon when it's not inflated is like about 1 centimeter, you said?
Mm-hmm.
So that part of it would not make a woman NIDA, because it's under 19 millimeters, 1.9 centimeters. Well, at least according to that, Saka from Moshe Feinstein, if you follow Postic that holds a different amount, then that might be different. But then I guess my question is, like, does the balloon actually, it's not like how does the dilation that happens manually, like, is it happening like from the balloon actually being there and causing the dilation, or is it like putting pressure and it's kind of happening on its own? Like, how is it working?
So it puts pressure on the cervix. There's no like set centimeters every few hours. It puts pressure on the cervix, which manually dilates it. And again, it irritates that whole entire area. Kind of think of a membrane sweep, where it's also, we're hoping, releasing some prostaglandins, which is the initial stages of labor, which is the softening of the cervix. So those are the two things. We call it manual dilation because a lot of times it will fall out and the patient will be, say, 3 or 4 centimeters. However, their effacement, the thickness of the cervix, because think of the cervix as like a turtleneck, right? The effacement usually will not be consistent with what's 4 centimeters for someone naturally in labor. So usually when someone's 4 centimeters, their effacement will be quite high, like 70% or so. Sometimes we'll have patients whose effacement is 50% with 4 centimeters, and that's just kind of not consistent. It's kind of like a not natural, artificial way of manually dilating the cervix. But yes, the actual intention is to manually dilate the cervix.
Right. So I guess that process of that manual dilation happening from this instrument that's there would cause NIDA. But it's not so black and white, again, because exactly like the actual like insertion of the catheter doesn't cause NIDA because that's not dilating, and then that pressure that's causing that manual dilation, like maybe it's one step removed. I think a case specific question should be asked if someone's having this. But it's really,
and it's not your only option. I think that's
right.
important to know. It's not your only option. So always discuss with your provider, what are my other options?
Right. I want to just also clarify, while we're talking all about this manual dilation versus natural, and people also go get checked for dilation at their appointments in their late 9th month. If you get checked for dilation at an appointment at your provider and you're told, oh, you're 3 centimeters dilated, that doesn't make you NIDA. Like the fact that you got naturally to 3 centimeters, which is a little bit inconsistent in the halacha here, right? Because if something external manually dilates you past 1.9 centimeters, then that would make you NIDA. But if you dilate on your own that far, then it doesn't. So I think that's something that's important to point out, so that people aren't confused by that. Or you are, but at least that there's a difference, because it's a little confusing.
And you can always ask a question if you're unsure about your status.
For sure.
And again, that stretching. it's good to actually, prior to having the exam, because a lot of times providers will just do it. They'll feel a soft cervix, so it's 3 centimeters. Great, let's stretch it. Maybe you're in
Right.
early labor. So that again probably begs to be a conversation between you and the halachic
Yeah,
authority and your provider, and say, maybe beforehand, please don't stretch my cervix.
for sure. For
And
sure.
what to do if they tell you after the fact, oh, I stretched your cervix, it was really soft.
Right. Oh,
Right.
it's better when you know before to ask.
Yeah, but a lot of times, most of the time, they won't tell you before. They'll just,
Right.
I know. I'll just be like, oh, I just did it. Thanks a lot. So, okay, before we run out of time, I want to make sure we get to the postpartum things, and specifically things that people asked about in the chat. So maybe we should talk about those first, just so we don't run out of time, and then we can come back to some of the other things we wanted to talk about. So the two questions that people asked in the chat about postpartum both had to do with birth control. One person asked, one person said that she's on the mini pill, which is the progesterone only pill that that's used commonly when women are breastfeeding. And is that okay? Is there a halachic preference to become a nida once a month, or is it totally fine to avoid becoming a nida? And I guess the assumption there is that the mini pill doesn't have any placebos, kind of just take it straight, and it's possible that if you're breastfeeding, that you wouldn't get a period on it, and that's fine. There's no, we say that there's no requirement to become a nida. If you become a nida, when you become a nida, their requirement of halacha is to follow the laws of nida, but there's no mitzvah to make yourself a nida every month. When you're pregnant, you're not a nida every month, and when you're breastfeeding, you're often not. When you're postmenopause, you're not, and there's no requirement throughout life to become nida every month, and that's totally fine. The other question that came up here, and Shir, maybe I'll, or Chani, this is also a question for you. Is there a particular time for insertion of an IUD that you find minimizes risk of uterine bleeding postpartum? Immediately postpartum versus 6 weeks postpartum versus after you got your first period back? How would continuous breastfeeding inform that ideal timing? So anyone have any thoughts about that?
Chani, do you want to give some thoughts medically, and then I'll take things from a halachic standpoint?
Yeah, so what this questioner is asking is there something called post-placental insertion of an IUD? And that's sometimes offered where right after the baby comes out, they can stick an IUD, and it's either, it can be done during a C-section as well. And the cervix is kind of open. And sometimes, if someone has a really hard time with these kinds of procedures with pap smears or whatever, maybe they'll have that offered to them. And it's something that has to be prearranged during pregnancy for insurance purposes. That is really not recommended especially with nida considerations. First of all, it has a high expulsion rate, as high, I think, as 30%. So, because if any of you had a baby, that we massage your uterus and we press on it, and your uterus is on its own contracting, so it can expel that IUD, firstly. And actually, I've had multiple conversations with Dr. Hellman about that from the Kampanakala, because that's her expertise, and she said how it really causes difficulty with getting clean in order to go to the mikvah. It's really not usually a good idea. And afterward, this is an interesting point, okay? Because usually providers like to schedule a separate appointment, not your postpartum appointment, but they like to schedule a separate appointment after that to insert your IUD, usually somewhere about 8 weeks. And again, that's for insurance purposes because they get paid separately for that. Whereas they will not do that at the postpartum visit. But it's interesting because oftentimes many women will be ready to go to mikvah prior to that. And if they don't want to get pregnant, then you need to have an alternative form of contraception. And some people will either not want to take something or whatnot in terms of intercourse. They may not want to have intercourse until after they have the IUD inserted, etc. So that's a separate conversation. But one other thing I want to say is that it's actually a lot more nida purposes wise, it's actually a lot better to get your IUD inserted after you've gone to the mikvah, not before, because after you've gone to the mikvah, you're going to have staining with the IUD insertion. But again, there are different things to rely on that would possibly not put you in nida. Versus if you get it before you go to mikvah, now you're going to be busy doing badiko, and that's, you're going to be seeing blood. You just are if you're having an IUD. So it is actually recommended. Many providers will prefer to do it when you're having your period. But from their standpoint, it's easier because your cervix is slightly more softer and easier to get the IUD in. But in terms of halachic, it is preferred to have it after you go to mikvah. So that's important to consider because you do want to have an alternative form of birth control prior to that, or not have intercourse, whatever the halacha, says.
Yeah, so definitely what Khani said has been my experience as well, that women who have an IUD when they're nida often have a very difficult time getting to mikveh, because when you are not nida, then you don't have to do bedikot, and any amount of red blood on a bedikot cloth would be problematic. And so when you're in a stage when you're required to do bedikot, any red that you're seeing complicates things halachically. And so sometimes women who get IUDs when they are nida will have a very long time until they're able to actually get to the mikveh and get out of their nida status. That being said, and Khani, maybe you can weigh in also from the medical standpoint. What I found is that often doctors will give women a window of time that they'll say, if you see staining after this insertion procedure, you can assume that it's coming from the process of putting it in and any scraping that happened on the cervix or on the uterus. And then we could rely on that to say that bleeding that you see came from that procedure. But then once it's past that window, if a woman starts bleeding again, then we would say that that is probably from the hormones that are starting to kick in, and that would be more problematic. So sometimes if a woman is still within that window of time that she has just had the insertion and she's almost ready to go to the mikveh, then she can get by, like scrape by and get to the mikveh quickly. But if it's happening earlier on in that process, then it will be much more difficult to get to the mikveh. Does that make sense to you from a medical standpoint?
Yeah, it does. I don't know the time frame. It's not something I heard of, but it's definitely possible. I mean, we hope that your cervix, that tissue heals. So yes, it's chemical again. The bleeding from an IUD from the chemicals from the actual medication versus from the actual procedure, the manipulation of very highly vascularized tissue. So, that's a conversation, I guess, with halacha, depending on everyone has such a different experience with their bleeding. So, some people do have weeks of bleeding, but they only have to use a panty liner and it's just slight staining. And some people have a lot of heavy bleeding, and it also depends on what kind of IUD you get, whether it's the one with hormones or the one without hormones. So these are all things to consider.
Right. In building off of that, Connie, I think just to answer this questioner's specific question about timing to actually minimize. A lot of times when a woman gets an IUD, let's say not postpartum, just any time in her life, at the beginning there could be a lot of staining and adjustment period. I think this woman is asking, like, is there a time postpartum that maybe that will be less, and especially if you're breastfeeding, maybe that will help make the adjustment staining to the IUD less. And I think, Connie, you can correct me if I'm wrong, but I think that's also very individual. Like, different women have different experiences, and it's hard to predict that and to know. And there's definitely, that's what we were talking about before, no guarantees.
It definitely will, but again, because you're not getting a regular period, and you'll speak to the halachic part of the vestot and with menstruation and expecting your menstruation, because typically with breastfeeding, it's very common not to have a set regular period. That actually might make things just a little bit easier in terms of, are you expecting this menstruation right now, or are you not because you were pregnant and now you're breastfeeding? So I think that in terms of that, it might actually make things easier when you are breastfeeding.
Right, definitely could help minimize that adjustment staining period. Okay, someone asked, are there things you can do postpartum to be able to get to the mikvah sooner? So from a halachic perspective,
I'm just going to pop in and say that I unfortunately have to leave this session a few minutes early because I have another session starting in 2 minutes. So it has been lovely to be with you today. I leave you in good hands with Khani and Dina.
Thank you, Shira.
It's a pleasure.
Okay, everyone's going to follow you to your next session after we're done here.
I can't believe it's time already. Wow.
I know, we're running out of time. I have so many more things we want to talk about.
Yeah.
But in terms of the halachically, in terms of things to be able to get to the mikvah sooner, so, it's always good, after you have a baby, and most commonly you haven't been to the mikvah or been, keeping the laws of nida for 9 months of pregnancy, to review, right? And typically you have to wait till you're done with any problematic colors of nida bleeding and then count the shivanikim and get to the mikvah. But, especially if it's been a long, it's starting to be like on the longer end of things and you're having a hard time and you're kind of having ongoing bleeding that's not really allowing you to get those good badikot. So it's worth the conversation of, at what point do you start maybe doing fewer badikot, or wearing a liner, or not, or wearing colored underwear during the Shiva Nikiim, and that's not a blanket, that statement that we could say at this point, but in a case by case basis, that's definitely a conversation worth having and a question worth asking. As far as medically, like, are there things you can do to help the bleeding stop? I turn to you on that.
There is absolutely. And the number one thing you can do is rest, because what happens is your placenta is about the size of a dinner plate. And when it comes out of your uterus, it leaves a wound. That's a big wound. And when you feel contractions after you give birth, that's your uterus contracting on that large wound and clotting it up and healing it. Now, if you are running around, you'll see, I do this education all the time when I discharge my patients. You'll have some days that are lighter days of bleeding. You'll have some days, and these are the immediate days, postpartum, weeks, postpartum. You'll have other days that are heavier days of bleeding. Usually when it's a heavier day of bleeding, it's because you've been running around and you've been overdoing it, because you have that wound that needs to heal. So really taking it easy is an actual thing to be able to get to mikvah earlier, okay? So obviously don't just lay in bed all day, take walks and gentle things, but don't go running around and, making an entire Shabbos and baking challah because you feel great 1 week after or 2 weeks after, which you might feel great. Some people, they're like, oh, great, my bleeding is dissipating. I feel great. It's 2 weeks. Let me go and do things. And then they pay for it the next day. So really wait a good 3-4 weeks of taking it easy. And a lot of times you'll see that you'll be able to get to mikvah much sooner.
So such good advice. And with that, I know our time is really up, but I really want to talk about this question. So Connie, is it okay if we just take 2 more minutes to address the question that we could really speak about for another, for hours and hours, which relates to actually what you posted about in your reel on Instagram. And it relates to taking it easy and resting, because in order to do that, you really need support and a support system and other people who are in your life helping you. So this comes up both in labor and delivery, and also postpartum, just kind of when when your needs are in labor and delivery and postpartum also, which means, that harchakot are in place, and there's, and aside from sex, which we've spoken about, there are other restrictions on physical intimacy and physical touch in general. What I want to talk about is just kind of like how that plays out when you need help, when you need support. So I'll start off by saying that in labor and delivery and immediately postpartum as well, a woman who has a baby is considered halachically a chola, right? She's considered someone who's sick, right? For lack of a better translation. In labor and delivery, like, she's considered a chola sheyesh bo sakana, right? I mean, she's in a life-threatening situation. We don't like to think of it like that, but it really,
and
really is dangerous.
24 hours postpartum as well.
Yeah. So, to the extent that there are other people available to do for her what she needs, that, once she does go into Nisa, and according to many post-game, like, she's not in Nisa in the process of labor until she's somewhat farther along in the process, and she can have the physical support of her husband until that point. From that point forward, when, to the extent that there are other people to help her with what she needs, that are available, then that's better. But if there are not other people available and she needs something, then her husband should do it for her, right? We might say, like, if you have to touch her, try to do it indirectly, right? Like through her clothing, or maybe he should wear gloves or something like that, to minimize that direct contact. But he should take care of her in the way that she needs. And I think the question that you referenced on Instagram, which I loved, was a situation where, a woman has to go to the bathroom, but she's postpartum, she's 24 hours after delivery, and she, is nervous or unable to get up and walk by herself, and she wants someone to help her, and there's no one on the units available. So certainly her husband should help her, right? She shouldn't not take care of her body in the way that she needs to. Because of that.
No, not just that, but emptying your bladder is extremely important during labor and postpartum. It can cause excessive bleeding if your bladder is full. So along with, just the bodily discomfort of having to go to the bathroom, you really need to empty your bladder. So from a medical standpoint, that's another consideration. And it's very common for women getting up for the first few times after they give birth to faint. So it's always recommended that either a staff member or their spouse stay in the room with them in case of emergency, because it's common.
For sure. And I don't, you can comment on this from your experience on the unit, but, sometimes like defining what someone else being available to help means is not so black and white. Like, yes, you could ask the nurses or the other people who are working on the unit to help, but if you need things, every 5 seconds, and they're going to start getting annoyed at you and resentful and not maybe give you as good care, so then that actually impacts also halachically, like what we would say you should do, right? We don't want to compromise your care from the medical professionals who do need to be the ones to do certain things. So if they're going to, unfortunately not provide you as good care because they got annoyed, then that's not something that we want to risk.
Right. And if you need to, because sometimes you will need to, then firstly, try to do it in a cluster. So don't ask them for something and then 5 minutes later call out for another thing, and then 5 minutes later call out for something else, because sometimes they'll do all the things they need to do in your room and then they'll run to another patient, and now they're
Right.
running back to you. So that's something that out of consideration to do for them. Secondly, when it comes to handing a baby to a mother, there are really alternatives. Oftentimes you can put the baby in the crib and put the crib right next to the mother's bed. There are on the actual bed, you can raise the bed, you can lower the bed, so you can make it crib height, so a mother can't get up yet after a C-section or an epidural or etc. So when it comes to like sometimes they'll see this being called out, can you please take the baby out and give it to the mother? The father can push it right next to the mother, and she can lean over. So some of the cribs they open, or the height becomes the mother's level. So it's just something that's also good to know. And what I see often is, let's say a mother is pushing and all the staff is busy with all the things and she's thirsty, she needs a drink of water. So I'm curious to know what this is, what you would say. But she needs a sip of water, and the staff will be like, can you please give her a sip of water? And we'll all be on like one other side with gloves and with other things, and it's hard for a staff member to come in every 5 minutes to give the mother a sip of water. So I'm just curious to know what your take on that is halachically.
So if she needs a sip of water and there's not other staff available who can do that because they're busy with other things, then her husband should give her a sip of water.
And sometimes it's using your judgment, where if you see your staff doing a million things and giving you medications and suturing you up and everything like that, yes, technically they can stop doing everything that they're doing to give you the sip of water, but it is a huge inconvenience on the staff, and it's going to delay them from doing other important tasks that medically they can do.
So that doesn't, so that, that might mean they're not available to do that.
Right.
And I think that's a really great point that, for couples going into this, to really like think about this beforehand and ask, have a conversation with your halachic guide about this beforehand, because you're not going to be able to ask a shaila there in the moment, like in labor, I need a sip of water, like text, whoever it's going to be, like, that's not practical. Like, you're going to have to make that judgment call on your own also in that moment. And you're not going to be able to discuss beforehand every single possible scenario of what you might need and what exactly the details are going to be. So you kind of have to get the overarching bigger picture guidance of what we're aiming to do, and then it's going to be a judgment call also on in terms of that.
One other important thing I want to also put out there is to consider really arranging for a female support as well as your husband being there. Obviously, everyone wants their husband there, but having someone female, not everyone can afford a doula, not everyone has someone else that they can have that they feel comfortable with. But also, usually overnight in a hospital, they'll only let one support person stay. And I have to say that you might want to consider not your husband being that one, but a female support person, because they can actually help you get out of bed and do all of those things. And maybe, maybe emotionally you prefer your husband, not crazy prefer, like you'll be happy and okay with the female support person, but you might want to consider doing that as well, because they'll just be more useful.
Right. Definitely all good things to think about in advance. And kind of segueing to, from this conversation to the conversation of, more longer term postpartum, even once you're out of the hospital, but still in needs that, like we were talking about for, for however many weeks, the harchakot and the lack of physical touch, lack of physical connection during that time can be really challenging. And another added layer on top of a big life transition and a, time period that's a hard adjustment. And
especially for people who are at risk for postpartum depression, postpartum anxiety, those who have no other support people.
Right. So that's what I really wanted to say, is that, it's something that we can really validate and acknowledge that it's really hard and challenging. And in a situation where someone is really at risk for postpartum depression, postpartum anxiety, something that maybe they've had before in a previous, pregnancy and postpartum period, or for whatever other reasons they have risk factors for it, that's not something to be taken lightly. And that definitely is there, that brings up the possible room for leniency. And if, that physical connection can help provide them with the support that they need that will help prevent or minimize that postpartum depression or postpartum anxiety. That's something that is really
And this
important
is
to
in
bring up.
labor as well. I need to say this
Yeah.
is also happens. I've seen these cases in labor as well, where a woman's gone through something very traumatic or very difficult in her past, and
Yeah.
she feels like she needs that, the touch from
Right.
some support from her husband. So again, these are these
Right. We don't want a situation. We don't want, and someone you posted about this. Someone actually wrote to me talking about how they were in a situation where they only kind of realized once it got to a situation where it was already pikuach nefesh, right, where it was already like a life-threatening level of postpartum depression, where it was so severe that they realized like how much that physical touch from their husband could have helped. And I was speaking to our posting about this case before we got on, for our session. And we don't want to, if someone is kind of sliding towards that, we want to prevent that situation. We don't want to let it get to that to say, oh, it's pikuach nefesh, now we can allow it. We want to prevent that situation. So it's definitely something really important to bring up in a conversation with your, halachic, whoever you turn to for halachic guidance, and really make sure that they understand the full picture and all the issues involved and the risk factors, and to get, really holistic guidance on that.
And I just want to bring up really quick, not many generations ago, we lived in nuclear families where we didn't live far away from our family, from the female help that we got from our mothers, from grandmothers, from aunts, from sisters. And when a woman had a baby, it was just common, normal practice. That was societal practice, where she'd be surrounded by her female, usually family, helping out.
Right.
We don't have that today, so that poses an extra challenge to be considered.
Right. And, for in those situations where, there's not postpartum depression, there's not postpartum anxiety, and it's just still hard and not fun and difficult. So, halachically speaking, like the halacha is still the halacha, but we can still validate and acknowledge that it's challenging and it's hard and it's not fun.
But there's something very beautiful about when a woman does go to mikvah postpartum for the first time. It is, many people say it's a new celebration. It's a new way to celebrate having the baby.
Right. So hopefully it's something that, from a bigger picture, when you're somewhat removed, you can look back on, it was all part of a very big transition and adjustment that was hard in a multitude of ways, but definitely something that, in situations of postpartum mental health questions should really be discussed and asked about and addressed. And not assume that there's no wiggle room, because we really want to make sure that people are getting the support that they need. Okay, so I feel like we had a lot of other things that we could talk about, that we wanted to talk about. I hope we answered people's questions that they asked here, that they asked beforehand, and we are available. All the Yoatzot Halacha, we at Nishman are available to answer any other questions that you have that we maybe didn't get to address here. And Chani, thank you so much for joining us. It was really a pleasure to have this conversation together.
My pleasure. And I just wanted to say, if for more education, I have an Instagram account called Yoadet Academy. And I also have a podcast, the Happy Birthway Podcast, which integrates all of these things into conversations. So
amazing. And you have your Yoadet community, right? I don't know if you want to.
Yes, and I have my Yoadet community, yoadetacademy.com. You can go look. I have after the birth course, and I have a community membership with lots of good benefits you can read about there.
Connie is an amazing resource, so we're really fortunate that you joined us tonight. Thank you so much.
Thank you so much,
everybody,
for having me.
Or have a good day. Actually, so I live in Israel. It's night for me, but have a good day, everybody.